Hi, everybody. Thanks for taking the time today. I know you're all very busy. I am currently unemployed, which is awesome. I am starting my own single specialty neurology and neurosurgery clinic in St. Louis. Very excited about what we're doing. We're going to have really great compassionate care, as I'm sure you all provide. And with that, we're going to have a lot of education initiatives. So we're going to have several seminars on site at the centers so you can get your hands really dirty learning neurology while we actually take care of real cases. And with that, industry like Zoometica and other wonderful vendors have gotten interested in what we're doing, and they're providing their best and brightest so that we can innovate and validate together. So it's an exciting new venture, but in the interim, I get to just lecture to you from my home, which is awesome in St. Louis. And in the background is Forest Park, which is a throwback to when parks were a really big deal in metropolitan areas. St. Louis's claim to fame is that we had two of the world's fairs here back in the early 1900s. So it's kind of cool to see the results of that. Anyway, today we're going to be talking about seizure management for you. There's been a lot of developments and changes in how we manage emergent seizures, so I'm excited to share that with you. But I think the most important part is talking about seizures in general. When you have an owner that has a dog with seizures, I think a lot of times veterinarians get anxious about that because we get anxious about neurology in general, but now you have these events that we don't really know exactly what causes them, but we just throw some medications and see if we can get them to be less severe. In the parents' world, this is probably the worst thing that they're ever going to experience with their pet. And they're going to experience it over and over again, and it changes their lives. This camera you could see in this title slide is put there purposefully because the owners want to know if their dog's having a seizure. So let's just talk about this in general. And warning, the video we're about to watch is tear-jerking. It's emotional. But we've all experienced it. The client that calls you on a Friday night and they say, my dog's having a seizure, and you're on your way out the clinic to celebrate your great weekend. You've been treating this dog, Mikey, here for several years, and you've maxed them out on drugs. And so you say, okay, we'll just try to up one of these medications and hang in there. And what's happening on their side of the phone receiver is this. They are going to be awake all night long with Mikey. They know that he's going to have 3 or 4 more of these events, and these events are horrible for them. They've gone through it time and time again as they watch their pet suffer through this. And what you'll see is other things happening in this video. Mom and dad are yelling at each other. Their other dog comes over and tries to help, puts both dad and the other dog in danger, and there's nothing they can do about it aside just watch it happen. Or is there? That's the question. So the reason I show this video is just a reminder that seizures are bad for us, but there's so much worse for the owners. Actually, I'll give you a challenge. Next time you have an owner that comes in that has a dog with seizures, generally a severe seizure dog or one that clusters, say, I've never had a dog with seizures before. Tell me what that's like, and just watch what happens. I guarantee you that they are going to tell you about how this experience has shaped their world, how nobody really understands, how they don't go on vacation anymore, and how the thought that they would mess up the care for their pet scares the heck out of them. It's a great reminder of how important treating these seizures are. So that's my pitch for trying to understand why we're having this conversation in the first place. Seizures are super common. They're actually the most common symptom-based disease in veterinary medicine. There's 10 times an incidence of seizures in dogs than there is in people. Essentially, what that means is 1 in 500 dogs is going to have epilepsy. These seizures are basically when your neurons are acting synchronously when they shouldn't be. When I describe seizures to a client, what I say is, we have all these cells and they're usually fluttering around. And as they're flooding around, they're kind of chatting with each other. But every once in a while, you'll get a seizure focus, which is a bunch of bad cells that start screaming in synchrony over and over and over again. So when you have this synchrony, those are the bad guys. And then you have a failure of the good guys saying, hey, cut that out. And the reason that's important is that all of our anti-seizure medications are going to affect seizures in one of two ways. They're either going to ask the bad guys to stop, or they're going to make the good guys better at stopping those bad neurons. So that's just a general principle. But when you approach a seizure, what I want you to ask yourself is three quick questions. Number one, is this a seizure at all? We have this Rottweiler here. He's having something that looks like a seizure. Is it a seizure? We're going to talk about things that help suggest to you things are seizures. Number two is, why is this seizuring happening? And number three is, how do I get this seizure to stop? So what do you guys think? I don't have a chat box up here. Susan, feel free to chime in if you see some cool questions in there. But basically, do you think this is a seizure? Yeah, that's definitely a seizure. Seizures can manifest in a lot of different ways. The most quote unquote minor form of seizures is focal simple seizures, like this little cat's having. You can see little motor dysfunction there where he's blinking and his ears are twitching. They're usually lateralized, but they could be bilateral. Those animals are normally conscious, which is important. You can have a seizure and be wide awake. That's a very important thing to understand. The signs depend on the area. If you have a seizure where the bad neurons are in your left frontal cortex, then you might have your fingers start twitching in your right hand. Or if it's in your right sensory lobe, you might feel little spiders on your arm. So it depends where the bad cells are operating, is what the symptoms will look like. Now, lots of people would call this seizure a petit mal seizure. And that's kind of one of those things that's entered the veterinary vernacular, but that's not a petit mal seizure. A petit mal seizure is more like this Pomeranian here. Children with absence seizures or petit mal seizures will become unconscious for a moment and then return to normal. There's very little psychomotor movements or motor movements associated with these events. So petit mal seizures are if I won't say that they're rare in veterinary medicine, but they're hard to identify in veterinary medicine. So we should use terms like focal seizures that are simple, or focal seizures are complex. And focal seizures that are complex now start to involve the limbic areas. So you'll start seeing things like abnormal behaviors, hypersalivation, lots of other autonomic dysfunction like pupils going in and out, hippus, or urination or defecation. But the most severe seizures are the generalized tonic-clonic seizures. They first get really rigid and stiff, hence the tonic, and then they go to clonic where they start paddling just like this. They tend to be also associated with all those autonomic dysfunctions, and they tend to last about 2 minutes. Notice that this cat is the same one that we looked at before. It's very common for these events to progress from a focal seizure to a generalized seizure. But things to look for are going to be things like the duration, the presence of hypersalivation, and other things like that. There's lots of different pretenders, but I always thought that this one was, to me, the most interesting. What do you guys think? Do you think this is a seizure? This is a 7-year-old cat that starts having these events where the legs draw up in weird positions and the neck gets turned in weird positions. And what you'll notice is that there's things about these events that are not consistent with the seizures that we've looked at. They don't have any clonic phase to them. There's no autonomic dysfunction associated with them, and they last for a really long time. We're actually seeing events like this emerge more and more in the veterinary literature. Does anybody know what this one is? These are what are known as the movement disorders, and the term that's being labeled with them is called a paroxysmal, meaning an event that comes and goes out of nowhere without any warning, dyskinesia, which is an abnormal movement. So PDs, or paroxysmal dyskinesias for short, and they can happen in the appendicular spine. They can happen in the face even. Look at this guy. He has these kind of cramping events of the face and of the nose. They're very difficult to distinguish from seizures, but telltale signs are going to be lack of autonomic dysfunction, long duration. They are conscious, which isn't necessarily a differentiator, but they just tend to have these kind of pulling in, cramping events. And what we also know about these is we're seeing a response of these events to a lack or a deprivation of gluten. There is some genetic evidence that a lot of these paroxysmal dyskinesias are associated with a gluten sensitivity. And if we put these dogs on a gluten-free diet like Royal Canin Ultimino or some of the Purina dermatologic diets, we see improvement. The other drug that can be really effective against these paroxysmal dyskinesias is zonisamide, which is not my favorite anti-seizure medication, but a valuable one for these events as well. So we can consider that. But paroxysmal dyskinesias are not the end-all be-all of the pretenders. We see other pretenders, syncope, narcolepsy, where dogs just get weak and pass out when they shouldn't. Even severe vestibular events. I had an event where I passed out once in the middle of surgery, if you can believe it. And when I went to get up, I could not get my bearings because my vestibular apparatus hadn't kind of rebooted. If you've ever passed out before, you'll know you've had these kind of jerky movements as you start getting back up. So vestibular events can look like that. The cramping disorders, even things like weakness from myasthenia gravis or severe neck pain can be mistaken for seizures. And so again, focus on the things like autonomic dysfunction, short duration, and the tonic-clonic events. So if we've decided that this is a seizure, the next question becomes, why is this seizure happening? And this is probably one of the biggest things that scares veterinarians, and it's also a place where we make mistakes. When I tell clients about seizures, I suggest to them that there's three general categories of things that can cause them. Something outside the brain bothering the brain, like a toxin, or if your liver wasn't able to take away inherent toxins from when you ate food, or if your kidneys weren't able to do the same thing, or if your electrolytes were off, or if your glucose was too low, blood sugar. Then you might have a seizure because your brain is either getting not enough of what it needs or bad stuff that bothers it. That usually resonates with them. The second possibility would be something wrong with the brain itself, something inside the brain like a tumor or inflammation or a stroke, or even if the brain was undergoing some degenerative processes that could cause seizures. But the third cause of seizures, the most common cause of seizures, is going to be idiopathic epilepsy. As you probably know, idiopathic epileptics are dogs that have seizures between the ages of 1 and 6, at least their first one. They tend to be, they can be very bad seizures, but they don't have to be. And they tend to run along certain breed lines. The frequency of idiopathic epilepsy is really high. And I believe the most recent literature suggests that if you have a seizure between the ages of 1 and 6, there's over an 88% chance that you're an idiopathic epileptic. However, once you get outside of that age range, the frequency with which it's idiopathic epilepsy drops off. So when you have a dog that comes in with seizures, the first thing I want you to do is make sure that you rule out the metabolic encephalopathies, especially in an emergent scenario like the one this lecture is focused on. So we need to do some immediate diagnostics. History. Does the dog have a reason to have a seizure? Then I want you to check glucose, calcium, BUN creatinine, ammonia, and or bile acids. Ammonia is probably better. It just needs to be point of care, and electrolytes. Now, while they may not be the most common causes of seizures, metabolic encephalopathies are the ones we can fix. So I want you to give immediate therapy based on those diagnostics. Sugar, you can blast them with sugar if you need to. Other things you want to correct a little bit more slowly, and we're not going to talk about sodium shifts and water shifts and things like that in this lecture, but just remember, if a dog has been deprived of water for a long time and now it's really hypernatremic, you don't want to flood them with IV fluids too quickly. You want to very slowly bring their sodium back into normal range. Hepatic encephalopathy we can fix pretty aggressively, and obviously detoxification is going to be important. But again, one of the greatest points of failure is a lack of recognition that there are many dogs that are having seizures that are not idiopathic epileptics. So what we're going to talk about the dogs that come in for emergency seizures. What are some telltale signs that, hey, maybe this is an idiopathic epilepsy? This is one of them. If you've ever seen a middle-aged female toy breed dog come in with seizures and you've treated them with seizures and then they didn't get better and maybe even they died, it's probably because they didn't have epilepsy. So what dogs should make you pause? Well, this Boston Terrier should make you pause. One, because it's outside the ages of 1 and 6. That should be really telltale. But the other is the fact that it has lateralized forebrain signs or behavior changes. If you see a dog that is circling, that has ipsilateral proprioceptive deficits, meaning knuckling as it walks, well, it used to be a happy dog and now is really mean, or used to be a mean dog and now is really happy, you should be thinking to yourself, hey, this is probably not idiopathic epilepsy. I need to revisit this. So that's one thing. Another is the ages. If you have a dog that's younger than 1 or older than 6, stop, think. This does not sound like an idiopathic epileptic. Maybe I need to kind of investigate if there's other reasons that they could be having a seizure. Number 3, the middle-aged toy breed dog, like I was alluding to with that Yorkshire Terrier. The frequency that we are identifying inflammatory diseases in the brain is increasing rapidly. Those acronyms that make you anxious, things like GME or NLE or MUO or MUE, it's basically what we have is a group of dogs that is predisposed to, for lack of a better word, immune-mediated inflammation or sterile inflammation of the brain that's not caused by an identified etiology outside of the inflammation itself. Not only are we seeing it in middle-aged toy breed female dogs, we're seeing it in a variety of dogs. I've seen it a lot in golden doodles recently for whatever reason. So just stop and think about the fact that Maltese and pugs, not common idiopathic epileptic breeds, and it's something to be mindful of. And then the last one that should make you skip a beat is the one that comes from the dog's owner that is concerned. This is a case I love to share. This is Mika Zabrino. She's a husky that I saw before I left St. Louis when I was last here. And her mom was an OBGYN, is an OBGYN. And we were talking about her dog, and this 7-year-old husky started having, had actually a single seizure. And despite the fact that I had my normal conversation with the physician, she looked unhappy. And I said, "You look unhappy. What's going on?" She's like, "I want an MRI done." And I said, "Okay, we can do that. What makes you say that?" And she says, "Something is wrong with my dog." And I said, "I understand that. You just told me that she had a seizure." She said, "No, something's wrong with my dog." And I said, "Well, tell me more." And she said, "I don't know. I just know that something's wrong." And I said, "Okay, I'm a smart neurologist. I didn't find anything wrong, but if you want to spend your money, let's do it." So we did an MRI, and this dog has a massive, massive brain tumor taking up over 20% of her brain. If I can slow the video down here for a second, do you see this white kind of large plaque-like lesion pushing the brain out of the way? That's a tumor. And lots of big tumors will not cause other problems other than seizures. In fact, I've been known to say that seizures are a blessing, and people look at me like I'm crazy. Well, the reason seizures are a blessing is that they're an early warning indicator of a problem. In other words, if you have a brain tumor, which I hope none of you do or ever will, but if you have a brain tumor, you're going to feel some funny things. You might smell things that aren't there. You might taste the color red. You might feel things on your skin that don't exist. And you would articulate that and say, "I better go see somebody." Dogs don't do that, not only because they're nonverbal beings, but also because they're meant to protect themselves. They don't want to show debilitated states. And so a seizure may be the only thing that lets you know something's wrong. And there's this misconception that we're really not great as veterinary neurologists and neurosurgeons at treating brain tumors. We're great at it. That's the dirty secret. The problem is that by the time we identify these masses, more often than not, it's too late because we've waited for a deficit or if we've waited for something else. So if you have a dog that has a seizure and something doesn't smell right, this is a real opportunity to help those animals by intervening earlier. What about cats? What cats should make you stop and say, "Hey, this is a little bit weird"? Well, the answer is all cats. Cats don't tend to get idiopathic epilepsy nearly as commonly as dogs. Do they get it? Yes, but it's not super common. And often it manifests as kind of strange behaviors or hypersalivating or things like that. So if you have a cat that has a seizure-like event, stop and say, that's not normal. Okay. So then moving on to question number 3. Oh, and by the way, with this cat, if a cat does that, that ain't right. So any types of compulsive behaviors, behavior changes, again, stop and think. Okay, so how do we get these seizures to stop is the most important thing. Well, you might say to yourself, well, why do I need to get the seizures to stop? Well, they taught me in vet school that it was really important. And I've always thought that was fascinating because we have lots of conditions where you don't go running around like a chicken with your head cut off trying to stop them, right? A dog comes in for coughing or vomiting. You're not going to clear the ICU trying to run to get some drugs. You're going to be like, okay, we'll deal with that in a moment. The reason why seizures are bad is a couple things. One is that seizures themselves are toxic to the brain. You have these neurotransmitters that are not supposed to be just running around the brain. They're supposed to be in these little spaces between the neurons where they talk to each other. And if they get outside that space, then they can cause a really big problem, excitotoxicity. So seizures are bad. We also know that sometimes seizures can cause spontaneous death. It's not common, but SUDEP, also known as sudden unexpected death in epileptic patients, does happen. And or seizures can turn into seizures that don't stop, the so-called status epilepticus, which is part of the reason I assume you're here for this lecture. So that's one reason. The other reason is seizures make the next seizure more common. It's called kindling or mirroring, but the brain, if it sees one seizure, it thinks to itself, okay, maybe I should just make some symmetrical neurons so that I'm balanced out, essentially. So seizures are something that once you start having one, the next one becomes more common and more common. But another reason why we feel compelled to get these seizures to stop is not only because of what it's doing to our patients, but what it's doing to our clients. Many clients that have dogs with idiopathic epilepsy will euthanize their dogs as a consequence of either the seizures or the side effects of the seizure medications we provide them with. So not only are seizures fatal from the standpoint that they can cause fatality, but more often, I would argue that more dogs die of seizures because of perceived quality of life problems than they do from the seizures itself. It also affects our pet parents significantly. If you can believe it, when tested, people that had dogs with seizures had a 40% higher cortisol level than those that didn't. It's a major variable in affecting our clients and our pets. And in that way, it's a very kind of special condition in that it makes us so compelled to treat both so quickly. So what I wanted to share with you now is how we get these seizures to stop. And fortunately, this group of really exceptional neurologists got together and created a consensus statement on the management of status epilepticus based on the evidence, not based on their opinions. And so what we're going to do is we're going to look at the evidence that they presented in these papers for both dogs and cats. Recognize that they look at the quality of the evidence and then make recommendations based on that. And so when we talk about seizures, what I'm going to do is present you with the data that they presented so that you can make the best decision for your pets. First things first, we need to get these seizures to stop. And so we're going to lean into the benzodiazepines. Everyone here has used Valium or diazepam for stopping seizures. And the reason why we've loved Valium is it's very effective and it's lipophilic, which means that it gets into the brain and is very effective very quickly. A couple of years ago, Valium went on back order and was really hard to get. It also has some other challenges. If you've ever pumped Valium outside of a vessel, it causes nasty phlebitis and it's got some issues. So people started playing around with midazolam, Versed, the water-soluble form of the benzodiazepines. And while we historically had thought that it wouldn't be a very good anti-seizure medication because of its pharmacokinetics, it's actually better. It's more potent. It is 5 times more available in humans. It causes quicker control and lesser recurrence in people. That's in people. In dogs, it has a shorter half-life and duration of action, and often requires a constant rate infusion. But it's extremely effective when given as a spot dose in a short period of time, and it's very effective when administered intranasally, which is a really attractive thing about it, because if you've ever had to wrestle a dog to the ground to get a vein, to try and get a drug into them while they're in the middle of the seizures, it's hard to do. So an intranasal opportunity is something that's very attractive. And in cats, Valium has some challenges. So what they did in the consensus statement is they said, okay, giving Valium, giving Versed, midazolam, diazepam, you decide which one you want to do. In our hospital, we don't even stock diazepam for this purpose any longer. We stock midazolam. So in this first-line therapy, they broke it down into out-of-hospital or in-hospital settings. And in my scheme here, what I did was I took the consensus statement, and when something had a lot of evidence behind it, I made it green. When something had moderate evidence behind it, I made it orange. And when something had poor evidence behind it, I made it red. Now, that does not mean that red is bad and green is good. That just means that we have evidence-based medicine to support the green and less evidence-based medicine to support the red. But I'd argue that in many cases here, red is the way to go. So for example, if a dog is having bad seizures outside the hospital, the way to go is intranasal midazolam in dogs and cats. Alternatives are rectal or intramuscular administration, but realistically, I don't know of any owner that shouldn't be doing intranasal unless they are fearful of getting bitten by their dog. In the hospital, even though intranasal can be as effective as intravenous, intravenous is always going to be preferred. And there really was no strength to dictate which one you should choose. But the doses are up there in the top right corner if you're interested. Now, sometimes, again, seizures can turn into more severe seizures. Maybe you don't get to stop that seizure with the one drug, and it continues on, and they can go into status epilepticus, which is a 5-minute seizure, essentially, or longer. There's a very high mortality rate associated with it, and it's a little different than clusters, but similar in effect. The biggest concern that I have when I have a dog that I've treated with seizures is what happens if I gave them that midazolam and they stop having that tonic-clonic phase, but they remain unconscious like this. My worry is that what if they're having a non-convulsant status epilepticus, a period of prolonged altered consciousness after successful management of convulsive seizures? And here's the dark cloud for you guys. Unless you have an EEG that is running on your dog, which I imagine most of you don't, you will not be able to distinguish a dog that you anesthetized from giving them a lot of a benzodiazepine versus a dog that is actually continuing to have seizures but without motor manifestation. Things that would kind of cue me into that would be I try to rouse them and I can't. Their unconsciousness remains for longer periods of time than I would expect. And then it gets kind of tricky because do you give more anti-seizure medications to the dog that is unconscious? People tend to leave this lecture very unsatisfied in that regard, but the truth is that if you have a dog that's unconscious following anti-seizure treatment, you have to recognize that you're in this kind of nebulous zone, and we likely in general practice don't have the tools to differentiate those things. So it's just something to be familiar with. But most importantly is this. I don't want you to hesitate in those situations to give benzodiazepines. Has any of you ever killed a dog with Valium or diazepam or midazolam? I doubt it. And so I want you to give when in question, give more. Now the consensus statement suggested that you should give a bolus and wait 5 minutes wait 2 minutes. And if ineffectual, then you should give another bolus. I don't wait 2 minutes. As a practicing neurologist, I wait about 15 seconds. And if they haven't had a seizure, if they continue to have a seizure, I'm going to give them another dose and another dose and another dose. I'll give them 4 or even 5 boluses within a minute if I have to. The drug should work. So I'm a little I don't exactly understand why 2 minutes was decided upon, other than that was arbitrarily what was decided in the literature. But I want you to give Valium or midazolam frequently, aggressively, and then put them on a CRI afterwards, especially if you've had to use more than 2 boluses. What should be your dose for the CRI? Here's a dirty way of doing it. There are calculations in plums, but my dirty way is I say, how much medication did I require to get the seizure to stop? Let's say it was 20 milligrams. Then I'm going to put them on 20 milligrams an hour for the next 4 hours and then slowly taper it back, cutting it by 50% every 4 hours. But that's kind of a dirty way to do it really quickly. Now, remember, you need to give it, sometimes the benzodiazepines aren't working, and you need to give a good second-line agent. And the best part about second-line agents is that they tend to be good long-term therapies, which we want to be initiating at the same time too. And so that's going to be things like Keppra, which has a lot of evidence to support it. I really like Keppra. Phenobarbital is going to be a close second. And fosphenytoin is if you're really in a pinch, but frankly, I don't know why you would ever have to reach that far down. So don't hesitate, regardless of the response, to add one of these second-line agents in. But this is what you do if you've been having trouble stopping the seizures as well. The third thing that you're going to do is now start reaching to some medications, which for many of you are likely to be a little bit novel. That's going to be things like ketamine and dexmedetomidine, and you can take a screenshot if you like here to kind of see the dosing, but both of them are extremely good anti-seizure medications. The main problem with dexmedetomidine, of course, is going to be some of the changes to heart rate, blood pressure, and whatnot, which is why it's so important to keep an eye on those things, which we'll discuss in a little bit. But ultimately, regardless of the second-line agent, if your dog continues to seizure and the CRI has not been effective, ketamine or dexmedetomidine are going to be your next best bet. If those two don't work, propofol is going to be your third bet. Propofol is an extremely strong and good anti-seizure medication. There's challenges associated with it, though. And one of the main challenges are the hemodynamic challenges. You can basically put these patients under anesthesia. And although sometimes that's necessary, it's less ideal than the alternatives. And that's why propofol has kind of dropped down to a step 2 third-line agent. But that's where you go. If those drugs haven't been effective, then the consensus statement recommends pentobarbital. However, just speaking candidly with you, if you've gone through all of these steps and propofol has been ineffective, it's probably time to start talking about euthanasia, because pentobarbital and inhalant anesthesia, my experience is that these dogs do not recover well. And even if they do recover, which is rare, the chances of them having another one of these events in the not distant future is very high. So it's just something to be aware of. So what are we going to do with these patients once we've started adding on these CRIs? Once we've started adding these CRIs on, we need a way to monitor them. We need a way to monitor them all the time, which is part of the reason why, as you know, this talk is sponsored by Zomedica, but also why it just dovetails so nicely into seizure management. We've been really excited about their VetGuardian platform, which essentially is a non-contact way of measuring heart rate, respiratory rate, temperature, and other variables. Now, the VetGuardian is not going to pick up on seizures, but I don't need it to. I have nurses that need loud beepy things to tell me if the medications I'm giving the dogs are causing them vital sign distress. Otherwise, if they're having a seizure, I may put a collar with bells on them, and I generally want a technician in the area. I just don't think technicians have the bandwidth to put dogs on a ketamine or dexmedetomidine CRI and just assume they're going to be okay. And so this is where something like the VetGuardian really shines. And the preliminary evidence out of VetGuardian is pretty exciting in that it's extremely comparable with contact type of vital measurements. And so we're a practice, especially my new practice, we're a practice that operates what we call lean and mean. We have less technical support with more autonomy, doing lots of things. And we've leaned into technology to enable us to do this. And the Vet Guardian is going to be basically a pillar of that, because it enables us to monitor vitals with patients that are having very aggressive anti-seizure care. When is it time to stop these anesthetics and third-line medications? Well, I like 12 hours where they haven't had a seizure, and then I start backing off these anti-seizure medications. I do it in the reverse order of administration. In other words, if I went from Valium, Keppra, ketamine, I'll take the ketamine away first, then I'll take the Keppra away next, and then I'll take the Valium away last. This is kind of my scheme to back them off, 25 to 50% decrease every step of the way. And if they recur, then we go back to the previous dose for 6 hours and then try to back off again the same way. And we want to make sure that we use multiple long-term agents. That's super important. Okay, so what are some alternatives here? Well, some people ask about clonazepam or clorazepate as this take-home drug to stop cluster events. And the jury's really out on that, but I want you to know that there's not a lot of evidence to support its use. I don't like this drug too much. I have clients that use it. I find dogs to be overly sedate when I send them home, but some neurologists really like this medication, and it can be a consideration for trying to stop dogs from having cluster seizures. There may be some alternatives coming. One of them is a drug called imepitoin, which is a benzodiazepine derivative that's used in Europe and may be adopted in the United States, but at present is not available. I want you to remember that we have some other long-term anti-seizure medications outside of Keppra. I like to call these the oldies. If you think about the oldies, they're not awesome. Phenobarbital and bromide have some challenges. They have mixed efficacy. They take some time between dosing them and when they're doing their job. They have a significant side effect profile, which includes catastrophic side effects potentially. They have a narrow therapeutic range and they can be expensive to monitor. However, there's a lot of advantages to phenobarbital and bromide. Number one, they're really inexpensive compared to the other drugs. Their efficacy, despite the fact that it's not awesome, is better than a lot of the new drugs. In fact, probably all of the new drugs. So they have a lot of value there. From a compliance standpoint, the old drugs have value in that they only have to be administered once or twice. They can be veterinary specific, and perhaps most importantly, they're synergistic with a lot of the other drugs like Keppra that you would use. Compliance is a big deal. You've walked into a room, you met a client for the second or third time, maybe fourth or fifth time, and they said, my dog has seizures. And you say, okay, what I'm going to do is I'm going to write a script, and I want you to give a drug 3 times a day, every day, for the rest of your dog's life. And if you miss a dose, your dog's going to seizure its brains out. That's not the way that most people are going to operate. They didn't get a dog to give it medication every day for fear that they're going to kill it if they don't do it right. And so if we can make our clients' lives easier with lower frequency of treatment, then we're going to be in much better shape. Okay. Sorry, my Spotify is listening to me. All right. The nature of doing things at home. Hey, Sonos. All right. Hold on one moment, please. Okay. I don't know if you guys can hear it in the background.
Download the latest on this app.
Just barely.
Barely. It's these are the joys of lecturing from home. It's very exciting. I may have to tend to that again. I hope you're all getting a good chuckle at home. Alexa, stop. It worked. All right, you guys, you need a little joy in life, right? We're messing around a little bit. Okay, so moving on, maintenance anticonvulsants. Remember, when you have a client conversation about these drugs, the goal is not to stop them altogether. We want to decrease the frequency, the duration, the severity, and the post-ictal effects. If we can get them to seizure once every 3 months, then we're doing much better. but I don't want you to overlook the disease severity, okay? Um, as veterinarians, we tend to use the frequency of seizures as the primary litmus test if our drug's working. In other words, if I put a dog on Keppra and it goes from having 3 seizures a week to 3 seizures a month, then I'm feeling pretty good about myself, right? But the client cares as much about the severity of the seizure as the frequency. If I don't change the frequency at all, but instead of 3 minutes of just being trashed and then post-ictal for a day versus having a couple twitches and then going back to normal, that's another important thing. So make sure when you're assessing how good you're doing, to think about more than just how frequent. And you're going to initiate these drugs at different times. If they have 1 seizure, most veterinarians are not going to reach for these anti-seizure medications, but you may have to. If there's an underlying reason for them, yes, put them on anti-seizure medications after their first event. Head trauma, they had a seizure, put them on Keppra, put them on something. Or if the first seizure was really bad, like a status epilepticus event, another time when we're going to want to start seizures after the or anti-seizure medication after the first seizure. And then I have a border collie here, border collies, Australian shepherds, Saint Bernards, Keesons. These are breeds that tend to have really bad epilepsy. When one of them walks in the door, even with 1 seizure, I put them on meds. What about other dogs? I usually wait to see if they're having more than 1 seizure every 12 weeks. If they're not having more than 1 seizure every 12 weeks, I'm usually going to avoid putting them on an anti-seizure medication because I'm not confident that I can make that better. So if a dog has 4 seizures a year, are you really going to ask them to be on life-altering medications for the rest of their life? I'm probably not, because there's not a lot of evidence to suggest that my treatment is going to change that patient's long-term outcome. So it's just something to think about. People say, well, where should I turn to if I have a seizure management questions? This book for me is getting a little long in the tooth, but it remains to be the best book if you're interested in only evaluating seizures. It's written by my colleague and friend, Sean Sanders, and I think it's a great resource. So when I talk to clients about these drugs, don't be afraid to talk to them about basic pharmacokinetics. I know it sounds like too much for the conversation, but the seeds that you sow today will grow into beautiful plants later on. If you teach your clients why you're making the decisions about the drugs that you're making, they're going to understand, they're going to be more compliant, and you're going to have a better relationship with them. So I say to them, these drugs can be in one of 3 places. They can be toxic where they're doing damage. They can be therapeutic where they're doing what we want them to do, or they could be subtherapeutic where we're not giving enough of it. And we need to keep them in the therapeutic range, which is hard to do. And the only way we do that is by administering them frequently based on their half-life. So that gets into our conversation about which drug to choose. I'm always going to reach for phenobarbital as my first-line anti-seizure medication in a severe seizuring patient because it is the most powerful anti-seizure medication that we have, even compared to bromide, which is another great drug that largely gets ignored. Phenobarbital has great pharmacokinetics, great bioavailability. It's really good at making the rest of the brain good at calming down seizures. So it's one of those drugs that tends to tell the brain to tell the bad guys to stop. And the thing we know about this medication is that it has a very wide, at least in the literature, therapeutic range. I'm going to give you a different way of thinking about phenobarbital. When I test phenobarbital, I want to see where it's at. But if it's too low, if it's low on my markers here, but the dog's not having seizures, I'm very happy. What I'm looking for is, am I getting into the toxic range? And I'm going to push this drug all the way to the top of the range. This is for those of you that are too young. This is the Price is Right Showcase Showdown. You want to go as high as you can without going over. I will usually push phenobarbital up until 38, 39, sometimes even 40 micrograms per milliliter before I give up on it. The Antec, IDEX, other reference labs that say that 30 mics per mil is possible toxicity, that's not really that well regarded by neurologists. So push it. Just don't push it past 38 if you're a little bit uncomfortable. and I'll recheck it over and over again if I think that I'm getting into a toxic range. But remember that phenobarbital over time actually is going to go down, not up. And the reason is because it is this funny drug that makes the liver actually work better, not worse. I mean, how weird is that? You're giving a liver toxic drug that's making the liver work better. Um, but remember that it affects hepatic metabolism. And so if you have a dog on these other drugs, it can affect their effectiveness. Um, and also remember, oh, my equation didn't come up, but there's equations to adjust the phenobarbital. And also remember that you don't want to use a serum separator when you're evaluating it, and it's going to make T4 look funny. People say, should I do peak or trough? And the evidence suggests that it really doesn't matter that much. So you can do peak or trough. Phenobarbital in cats. This is a new thing that I want to share with you. Phenobarbital was the drug of choice in cats. It's extremely effective. It also has a very wide therapeutic range compared to dogs, and you can keep it lower. The problem with phenobarbital is that you have to give it twice a day to cats, as opposed to some of the other novel drugs like zonisamide, which you could give once a day. But a new piece of literature just came out in the last year, which suggested that phenobarbital given once a day has favorable pharmacokinetics. So I'll often give phenobarbital 3 mg per kg once per day and see how cats do. And if it stops their seizures, then I'm very happy. And that is that paper right there. So it's in the feline Journal of Feline Medicine and Surgery. So consider that use. The other drug that we forget about is potassium bromide. It's 46% bioavailable in humans, which is why it's a drug that they don't use. If you tell one of your friends that has epilepsy, have you tried bromide? They're going to look at you like you're crazy. It's strictly a dog drug. But basically, it works very, very similar to phenobarbital. And despite the fact that it has some side effects like dopiness and incoordination in the pelvic limbs and mild PUPD, compared to phenobarbital, it has less catastrophic side effects. So I really like bromide. Remember, bromide is a salt. Sodium chloride and potassium bromide sound very similar because they're both salts. And so if you see any changes to the amount of salt in the diet, or even in the air, believe it or not, you can see changes to the bromide levels. We use this to our advantage. If we have a dog that we think has developed too high of a bromide, we'll give them IV fluids and a diuretic, and we'll see that level plummet really quickly. But you have to be mindful of that. You also have to be mindful of the fact that bromide is not a good choice for cats. The reason is because they can get a eosinophilic pneumonitis that kills them. There's no scenario now with modern anti-seizure medications being what they are that you should reach for bromide in cats. So I like bromide and phenobarbital a lot, as you can tell, especially in these emergent cases that need strong long-term care. I like phenobarbital when I want a drug that's going to work, period. That's my go-to. Bromide has a lot of advantages because of its lack of liver toxicosis, and also because it's effective. It's great for young animals who you don't want to have on a liver taxing drug for the rest of their life. It also has such a long half-life that if an owner forgets a dose or 2 doses, it's great because it'll still remain pretty high in the system. The other nice thing about bromide is that I don't have to worry about a client not testing frequently enough. In other words, how many of you have had that client that wants their phenobarbital refill, but they haven't had their drug levels tested in a while, and you say to yourself, am I going to put my license at risk, or am I going to make this client angry at me by not giving them more medications until they come in for a drug level? With bromide, you don't have to worry about that because there's no scenario where they're going to get into such a toxic range that you can't refill it, or you would have seen those physically. So that's great. It's great for dogs with liver dysfunction or a history of immune-mediated disease or are hypothyroid. So don't forget about bromide. Keppra, I have 1 slide on it. And it's because everybody knows that Keppra is a very valuable drug. Can it be a valuable monotherapy? Sure. In the really bad seizuring patient, do I like Keppra alone? No, I don't find it to be as effective. But remember that Keppra is synergistic with both phenobarbital and bromide because Keppra takes down the excitation of those bad cells, phenobarbital or bromide increases the effectiveness or the inhibition in the brain in general. So they're both good drugs to put together, and Keppra has some other benefits that may make more seizures less frequent. Zonisamide is the other major agent that's often reached for in emergent cases for long-term care. Here's the truth, guys. Zonisamide is not thought to be as effective as these other medications we've talked about. That doesn't mean it doesn't work. That just means that if you have a severe epileptic, this is probably not the drug to choose. And it has some other challenges, including some liver toxicoses and renal tubular acidosis. I like zonisamide, but I like it for my minor seizure cases, not my more severe ones. And when we look at the table of evidence to support these medications, zonisamide has the least amount of evidence supporting its use. I want to give a nod to imepitoin. Again, it's this partial benzodiazepine agonist. It's likely to enter our world at some point, and it could be an effective ancillary therapy and also may have some value in decreasing the likelihood of cluster seizures. So that's a good thing. The other new agent that's not new, but starting to enter our sphere for these emergent anti-seizure cases is topiramate, also known as Topiramax, one of the most common anti-seizure medications used in humans. It has so much value, as you can see here. The problem is the blue. The half-life is extremely short in dogs. Our dog livers are just better than ours. Don't get into a drinking contest with the dog. And the problem with that is it means that you have to give topiramate 4 or even 5 times a day to reach some type of steady state. Now, that's not to say we don't reach for it every once in a while. We try it when we get a little bit stuck, but I think it's likely that topiramate is going to be a drug that we explore more, especially as we can manipulate it to have more favorable pharmacokinetics. It has some minor side effects, but those side effects are considered low, and we really don't have a way of monitoring it. But I like to put up and coming things on your radar because I think you will get some exposure to it. So that's what I wanted to share with you. Ultimately, the goal is to stop these seizures right away. And now we have an algorithm. You don't have to feel lost. You go from your benzodiazepine to your Keppra phenobarbital to ketamine and dexmedetomidine and propofol if needed. And then remember, not only do I need to give them in the short term, but I need to keep pushing the long-term therapies. And then lastly, and that was it, I want to make sure that you're using them together. So that's what I wanted to share with you.